This is part 2 of treatment of bipolar disorder. The last atypical antipsychotic we're looking at is clozapine or Clozaril. It's only approved for treatment-resistant schizophrenia, so usually it's a last line of treatment for somebody who's diagnosed with schizophrenia. But it's also used to treat severe mania. It does require weekly blood monitoring of white blood cell count. There's significant side effects, so fever, weakness due to decreased granulocytes in the blood, and seizures. So other side effects: weight gain, sedation, headache, orthostatic hypertension, constipation, salivation, increased heart rate, inflammation of the heart. Not known to impact the fetus, but may be used during pregnancy if the benefits outweigh the risks. So somebody whose symptoms of bipolar or schizophrenia need to be treated, or looking at the risks of that, then they might continue treatment. So some typical antipsychotic medications for the treatment of bipolar disorder. These are usually used as adjuncts, so meaning they're added to another medication. So some examples: Haldol, Thorazine. These are used for acute agitation while someone's in hospital, so usually not used for long term. They're usually given as an injection or by mouth, but they also do cause significant side effects, including EPS. There is a fact sheet here on EPS symptoms to look out for people who are taking these medications. These medications are usually only used for behavioral management reasons and for short term, so waiting for other medications to start treating symptoms. So other medications using to treat hypertension and angina, they seem to show some anti-manic properties. Benzodiazepines might be useful as an adjunct medication as well. So example, Ativan, using to decrease agitation until the mood stabilizing medication is effective. And omega-3 fatty acids, this can be used in combination with lithium. Here's a website from the BC Children's Hospital regarding treatment of bipolar disorder during pregnancy and right after the baby's born. There's also a website here from the Mood Disorder Society of Canada regarding bipolar disorder. So ECT can also be used for people who are diagnosed with bipolar in some severe manic patients who are unresponsive to other medications. So again, this might be a last line of treatment. And during the depressed phase of bipolar disorder, where suicidal ideation is present and needing a rapid response, so treating the depressive symptoms quickly. But again, you must weigh the benefits against the risks of ECT. So looking at treatment resistance and protocols. So in the manic treatment protocol, step 1, we're using an approved medication for acute mania. So you need to treat the manic symptoms quickly. So something like lithium or a valproate would be your first choices. But if there's psychotic symptoms, you might look at an atypical antipsychotic medication. For someone who has acute mania, they usually need to be hospitalized for this type of treatment, and need about 5 to 15 days for this medication to start and to evaluate if it's working. Step 2, again, if the first drug trial fails or there's too many side effects, you might need to switch. If taking only one medication fails, you might want to add another one. And this doesn't work, try a different combination of medication would be indicated at that point. Step 4, if 2 drugs don't work, maybe try a third. For example, lithium, adding an anticonvulsant and an atypical antipsychotic. But if this doesn't work, looking at ECT or clozapine. Step 5, if nothing else is working, should reassess the diagnosis. There might be a comorbid medical condition, so something physical going on. Could be something with compliance, so maybe the person's not taking their medication as prescribed, or some other substance use issues going on. So your depression protocol, so looking at somebody who has a bipolar diagnosis, but during a depression phase, looking at a mood stabilizing medication. Step 2, you might want to add an an SSRI or bupropion, or maybe lamotrigine rather than an antidepressant. But again, being cautious with combining lamotrigine with valproate because of the toxic rash. Step 3 might combine 2 antidepressants with a mood stabilizer. So for example, looking at venlafaxine or nefazodone with other antidepressants to be added to SSRI or bupropion. Lamotrigine can be added to another antidepressant as well. Step 4, add an atypical psychotic or MAOI. After that, you might use ECT, thyroid hormones, typical antipsychotics, tricyclic antidepressants, hormones, omega-3 fatty acids, or other psychostimulants like ADHD type medications. So looking at a mixed mood state treatment protocol. So step 1, looking at atypical forms of a bipolar disorder respond best to an anticonvulsant or atypical antipsychotics rather than lithium, so like a valproate or olanzapine. The step 2, if first choice does not work, change the opposite medication. So step 3, so 2-drug combination would be next, followed by 3-drug, but always keep the treatment logical. Keep the treatment plan simple. If you're starting to add too many medications, it doesn't make a lot of sense, so keeping it to a minimum. So some patient education. So counselors, so us as supports, must assess the patient's level of understanding and to fill in the gaps in knowledge that might be lacking. So first step is to provide a natural history, looking at symptoms, comorbidities, and various treatments of bipolar, so giving all this explanations. The best way is for the person to read about the illness and talk to others, maybe support groups to help normalize experience. So if they see other people who are diagnosed with bipolar and have a similar experience, that might help them to feel more normalized. Compliance with treatment can be difficult. So somebody with bipolar sometimes misses the feeling of the euphoric mania. It can be an enjoyable experience, so sometimes people prefer to be back in that state, even though it can be very risky and very detrimental. Need to reassess a person's use of alcohol and drugs. They might be minimizing their use, which can complicate the person's response to medication. Medication won't work as well. The person may forget to tell a doctor that they drink alcohol, which can contribute to symptoms as well. So some family education. So as a clinician, can help the family to understand that the person may not want to lose the euphoric feeling. The family may be helpful in monitoring the person's compliance with the medication. And the clinician should ask the family about symptoms, compliance issues, and be involved in implementing a treatment plan. So it is a family support. And can also refer family members for their own treatment if they're having difficulty coping with the person's behaviors. So some family education and family support can be necessary as well.